Hello, coders. Good morning, good evening, good afternoon, all depending upon where you're joining us from. Welcome back to another CPT Guideline Mastery session here at AMCI. How are you all doing, coders? Let me have a quick look into the chat. Thank you, Miss Mills, for letting me know that. Okay, so I can see Miss Mills have joined here with us from Team AMCI. We have Miss Catherine as well. Who else are there? Hi, Tanya. Hi, Shafiri. Hi, Miss Sabrina. Hi, Kaihora. Hi, Miss Linda. Okay, hi, Becky. All right, so I can see a lot of people are there in the chat. Drop a hi. Okay, so yes. So I hope you all are having a wonderful day so far and are ready to sharpen your coding skills. So let's not waste much time. And throughout today's session, I really would encourage everyone to keep your CPT manual open. And I don't want this to be another lecture. I want it to be an interactive session. So I'll be asking questions throughout the presentation. So don't hesitate to participate. Also, don't hesitate to put your answers in the chat whenever we are doing any scenarios. All right, no matter if you are right or wrong, it doesn't matter at all. So participation is what we value a lot. All right, so don't forget to put your answers in the chat. So let's get started and let's begin by reading out the copyright. CPD Copyright 2026, American Medical Association, all rights reserved. CPC is a registered trademark of AAPC. The AAPC content found within this presentation is a copyright of AAPC. Keyword concept FDR Chun, AMCI FAB 7, AMCI ICD 10, Flip Tab, and MCG are the trademark of AMCI. The credentials CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC. AMCI do not own right to these credentials. The credentials CCA, CCS, CCSP, RHIA, RHIT are owned by AHIMA. AMCI do not own right to these credentials. Okay, so before we begin today's session, once again, a quick reminder to kindly fill out the survey form. I will be just placing them in the chat for the time being so that in case if you're leaving in middle, you can fill that survey form. So please don't forget to fill out that survey form. We take your feedback very seriously and it is very important for us. All right, so I used to pick topics for the sessions from your feedbacks as well. So today also one of the topic which I picked the topic which I picked for today's session is from previous sessions of feedback. And yes, I know you all have been engaging actively with us in the chat right now, but only few complete the survey form. So please do complete that survey form for us towards the end, and it will really take less than 1 minute. Okay, hi Letty. Okay, Letty is here. Welcome everyone to the CPT Guideline Mastery session once again. So today we are going to explore a topic which is urinary stone removal coding or urolithiasis, otherwise we can call them. So this is one of the most common procedure that we will see across the urinary department or urology department in your hospital. And yes, we haven't done much lectures on these procedures, so I thought, why not? Why not? Today we will pick that topic and let's have a great session on it. So, at first glance, many of these procedures seems very similar, but to be honest, you have a different classification or different types of procedure that is done to remove the urinary stone. And we will be going through each of them today, one by one. So these procedures are found under your urinary system chapter, and I can't really find out a specific area in this chapter where you will find this code because, as you know, the urinary stone can be found in different parts of your urinary system, right? It can be in the kidney, it can be in the ureter, bladder, urethra. So you will find these procedures actually spread across the urinary system chapter. So let's go ahead, let's begin. And before jumping into the coding, let's first try to understand what a urinary stone actually is. So, a urinary stone is also called as a urinary calculus, is simply hard mass forms when minerals and salt that present in your urine begin to crystallize and stick together. So, let me say, think of it like a sugar crystal forming when syrup begins highly concentrated. And over time, these crystals grows into stones, right? Now, these stones can develop anywhere in the urinary tract. It can you can find it in your kidneys, it can be in the ureter, the bladder, or even urethra. And however, the kidneys are by far the most common site where they begins. So let's quickly look at the process. Look at the process that lead to a stone formation. So urine initially becomes highly concentrated. It starts with the process known as supersaturation, where the urine becomes highly concentrated, and this can occur because of various reasons such as dehydration or sometimes due to some metabolic condition. So after supersaturation, minerals start forming tiny crystals, and these crystals gradually will stick together. You can find you can refer to the image I've attached here. So these crystals will stick together and continue to accumulate more and more minerals, and eventually it will become a stone. And once a stone is large enough, it may remain inside the kidney without causing symptoms, or may sometimes it will begin to travel into the ureter. And once these stones start traveling, that's when patient usually experience the classic severe pain associated with the kidney stones. Okay, now let's look at different type of stones that are commonly seen. So there are four main type of stone. First one is the calcium stone, and it accounts for nearly 80 percentage of all the urinary stone. So that's the most common type of urinary stone. And next we have the uric acid stone. So that is found in patient with acidic urine or in conditions such as gout. Then we have struvite stones, and finally, there is cystine stone as well. So cystine stone is much less common, and it is usually seen in patients with hereditary metabolic disorders. All right, so these are the four type of stone. Now that we understand the urinary stone, next question is how do we treat urinary stones? Well, answer actually depends upon two things: how large the stone is and where is it located. So let's start with easy one. Small stones, usually less than 5 millimeter, they often pass on their own, right? And the patients are usually here treated with conservative methods like hydration. Sometimes the pain medication will be given, or sometimes other medications given to relax the ureter and help the stone to pass naturally. But what happens when the stone is too large? And that's when the intervention becomes necessary. And depending upon the patient's condition, physician may opt to treat the stone using different techniques, like you have shockwave lithotripsy, you have stone removal using the endoscopes. It can be also removed through open procedures. So there are different approaches to the stone removal that we will be learning today. And every stone removal procedure is driven by two questions. Always remember that for the coding perspective. Question number one: where is the stone? Question number two: how is the surgeon getting to it, or otherwise the approach for stone removal. Okay, so yes. So as I said, there are two steps or two important questions that you must keep in mind. That is one, anatomy, which is a location. Second one is a surgical approach. And the composition of the stone plays little or no role in code selection. Okay, I just want to let you all know that. And yes, let's first talk about the location of the stone. The first question. So in many urinary stone removal procedure, prefix actually or prefix of the procedure name actually tells you where the procedure begins or where the procedure is being performed. Now, if you can identify the prefix in the operative report, I would say you have already halfway to selecting the correct CPT code. So let's look at common prefix you encounter in these procedures. First one, nephro. Nephro, you all know nephro refers to the kidney, right? So if the stone is within the kidney tissue and surgeon performs a procedure throughout the kidney or through the kidney itself, you will see procedures such as nephrolithotomy, etc. Next is pylo. Pylo refers to the renal pelvis. So if the stone is located in the renal pelvis and procedure is done over there, you will call it as, or the prefix is called as pylo. For example, pylolithotomy. And then we have uretero, which refers to the ureter, and cysto, that refers to the urinary bladder. So whenever you're reading an operative report, don't immediately jump into the CPT codes. Instead, first identify the anatomical prefix used in the procedure name. All right. Now let's move on to the second point, which I was talking about. Whenever possible, physician will start with least invasive option, that is a medical management. So the medical management includes pain control, hydration, etc. And since no procedure is performed here, we are not going to give a CPT code. You may assign the ENM codes accordingly. So for the medical treatment, there is no procedure codes. Now next one is the external shock wave lithotripsy, or we call this as ESWL. This is a kind of non-invasive treatment for stone removal. I will be explaining more about ESWL in the next slide. So just remember, ESWL is one of the non-invasive fragmentation method. The second way or second approach to treat the urinary stone is endoscopic approach. So a ureteroscope will be inserted and stone will be treated accordingly. An important thing to remember here is that using an endoscopic approach, here the physician use natural orifice as access. So here also no incision is made, or no incision. Yeah, there's no incision made in endoscopic approach. The third one, that is percutaneous or PCNL. That's what I would say. Yeah, PCNL, percutaneous procedures. So here sometimes stone is simply too large or too complex for endoscopic approach. They are treated using PCNL. And finally comes open surgery. All right, so we are going to open surgery is less common these days and are generally reserved for very large stone or sometimes very complex renal anatomy. Only in those cases open surgery approach is used. And okay, so next let's go on to the first technique or first approach which I was talking about, the ESWL, or extracorporeal shock wave lithotripsy. So the word extracorporeal literally means outside the body. So instead of inserting an instrument into the urinary tract or making an incision, a specialized machine or a specialized device generates high energy shock waves. You can see that in the slide which I've shown. It will create high energy shock waves, and these waves are carefully focused onto the stone using image guidance such as a fluoroscopy or ultrasound, right? So shock waves repeatedly strike the stone and gradually breaking it into smaller and smaller fragments. So once the fragments are small enough, the patient passes them naturally through the urine over the next several days or weeks. So remember, nothing is inserted into the kidney here, as well as nothing is removed during this procedure. We are simply breaking the stone into smaller pieces and allowing nature to finish the job. Okay. All right. Some patients also might require more than one session of ESWL, depending upon the size of the stone. Okay. Now, from the coding perspective, the CPT code used for ESWL procedure is 5059590, and we have only one CPT code for this procedure. So whenever you read that term or whenever you see that term, extracorporeal shock wave, go for ESWL codes. All right. Okay. Now moving on to the next one. Okay. Here the physician treats the stone. Here also, that is a scopy. The second one is also, I'm talking about the scopy procedure, where the physician treats the patient again without. No, here. All right. Okay, let's begin from the first. So in the ureteroscopy procedure, what physician do is that he will insert an endoscopy. Here also no incision is made. So you can see the image on the left. You can follow the blue arrow. So here no incision is made. Instead, physician will reach the stone using body's natural urinary pathway. Okay. So once again, you can follow the blue arrow in the diagram. So ureteroscope is inserted, that is a device. Ureteroscope is inserted through the urethra and it passes into the bladder. Then it will continue up until the ureter or until it reaches the stone. And this movement is called as retrograde approach, because we are traveling against the natural or normal flow of the urine, right? So urine normally flows from the kidney down to the ureter and then into the bladder. So during the ureteroscopy, we are doing exactly opposite. We are moving from the bladder up to the kidney. Now, once a stone is visualized, surgeon has two options. If the stone is small enough, it can simply captured using a stone basket, just like the image on the right, and it is generally pulled out intact. But what if the stone is too large to fit through the ureter? That's where we use a procedure known as laser lithotripsy. And in laser lithotripsy, instead of pulling the entire stone out, surgeon first fits a laser fiber through the ureteroscope, and this laser fiber will break the stone into smaller fragments. And those fragments are either removed through the basket or allowed to pass naturally after the procedure. All right. So next, let's look at the CPT codes. And the CPT code depends upon the final procedure performed after insertion of the scope or insertion of the ureteroscope. So if the physician only manipulates or removes something from the bladder during the cystourethropy, we use code 52320. If the surgeon removes the ureteral stone intact using a basket, you use CPT code 52352. And if the surgeon performs a laser lithotripsy by breaking the stone apart before removal, that's when you use code 52353. All right. Also, we have fourth code, that is, if the physician performs a laser lithotripsy and then places a ureteral stent during the same procedure, then the correct code becomes 52356. So there are four codes within the ureteroscopy the scopy category. And or again, once again, remember coders, the code selection depends upon the final procedure performed. All right, I hope it is clear. You can put in the chat if you have any questions. Okay, now we have covered two treatment options. First is ESWL. The second one is the scopy procedure, right? Yes. Now we are looking into the third approach, percutaneous nephrolithotomy, or simply we can call them PCNL. And this is okay, this is unlike ureteroscopy technique. The physician is not traveling through the urethra or bladder. Instead, a small incision is made in patient's back, creating direct pathway into the kidney. Right? You can see that in the image. All right. So the word percutaneous literally means through skin. So remember, we are traveling from the skin through skin to the kidney, and that is the entire concept. Now let's walk through the procedure. You can see the steps involved in PCNL. First step, the physician will be or physician makes a needle puncture through the patient's back into the kidney. Second step, a guide wire will be inserted to establish the access. Next, the tract is gradually dilated to create enough space for surgical instruments. And third, once the tract is large enough, a nephroscope is introduced directly into the kidney. And then surgeon will visualize the stone. If necessary, stone fragments is removed using lithotripsy, or the stone fragments are broken down using lithotripsy and later fragments are removed. Finally, at the end of the procedure, physician may leave a nephrostomy tube or urethral stent to help with the drainage or during the healing process. So unlike ureteroscopy, surgeon now has direct access into the kidney, making this procedure very ideal for large or complex stone removal or stone treatment procedure. All right, so that is the difference. Percutaneous nephrolithotomy means through the skin. So we covered ESWL, which is most non-invasive method. We moved on to the scopy, which is a bit more invasive, but still no incision will be made. Third one is percutaneous nephrolithotomy procedure, where that is an invasive method, where a minimal incision will be made to the skin and stone will be removed. All right, so we covered three approaches. Next, okay, before we move on, let me give you or let me show you the CPT codes that is used for PCNL procedure. So there are two types of PCNL CPT codes. First one is simple PCNL codes, and it is coded using CPT 50080. The second one is complex, and here the CPT code used is 50081. And you can see the difference between these two codes. In 50080 is used when the stone size is less than 2 centimeter. Stone will be located or stone will be having only one location, and the stone is usually non-branching stone. While in complex PCNL procedure, the stone size is greater than 2 centimeter, and or otherwise there will be multiple stones or multiple stone locations. Okay, and the morphology of the stone will be, it will be branching stone. Okay, or otherwise, if PCNL is performed on a complicated renal anatomy, then also we can consider the PCNL as a complex PCNL. So it's important to differentiate between simple and complex PCNL. So these are the CPT codes, and you can see a lot of parenthetical guideline. Make sure you read all these parenthetical guidelines, all right? Because you have the guidelines on bilateral reporting, bundled services, as well as separately reportable services. So please make sure you read the parenthetical guidelines. Okay, now we are moving on to the final type of approach, that is open procedure. So far we discussed minimally invasive techniques, but occasionally you will still encounter cases where surgeon performs open stone surgery. So first thing to understand is that open stone procedures are classified based on where the surgeon makes incision, not simply where the stone is located. So that's a key concept for this slide. And open surgery typically reserved for patients with very large stone or complex renal anatomy, or when minimally invasive procedures like PCNL have failed. Now, let's begin with nephrolithotomy. That means incision into the kidney. So, nephro means kidney, lithotomy means incision to remove the stone. So, remember the prefix I was talking about? So in nephrolithotomy, surgeon makes incision directly into the kidney to remove the calculus. And within this category, you will commonly see four types of CPT code. 50060, that is used for open nephrolithotomy. 50065, that is used for secondary nephrolithotomy. This is reported when repeat nephrolithotomy is required after the previous procedure. All right. And third is 50070 over here, 50070, which is used for nephrolithotomy complicated by congenital anomalies. So here the surgery is more difficult because congenital renal anomaly making the procedure technically challenging. And we have next code 50075, which is used for removal of large staghorn calculus. So remember, staghorn calculus branches into multiple calluses and occupies large portion of your collecting system. So when you have a staghorn calculus removed by open procedure, you will use CPT code 50075. Okay, next we are moving on to pylolithotomy. So pylo refers to the renal pelvis. So here, instead of cutting into the kidneys itself, the surgeon make incision into the renal pelvis and removes a stone from there. And they are reported with the CPT code 50130. Okay, so the major difference is the site of incision, not simply where stone happens to be. Okay, now let's move on to the open kidney stone surgery, from the open kidney stone surgery to open ureteral stone surgery. So you can see how these codes are changing depending upon the location of the procedure. Okay, so now we are talking about ureteral stone open surgery, or commonly known as open ureterolithotomy. And unlike nephrolithotomy or pylolithotomy, where codes were based on the site of incision, in open ureterolithotomy, coding depends entirely on where the ureter or where along the ureter the surgeon opens. So think of ureter being divided into three equal sections. Okay, you can divide the ureter into three sections, and once you identify which third the stone is located, then you have identified the correct CPT code. So if the surgeon makes incision into the upper one third of the ureter, you can report CPT code 50610. So this includes stones that are located near or close or proximal to the kidney. Not proximal to the kidney, near the kidney. Okay. And if the stone is in the middle one third of the ureter over here, then you use CPT code 50620. Finally, if the surgeon opens the lower one third of the ureter towards the bottom, and that's when you use code 50630. All right. So that's how open ureterolithotomy codes are classified. Okay. Now, finally, we are moving to the another open procedure, that is open stone procedure performed on the bladder, or we can call cystolithotomy. So cysto means urinary bladder, and lithotomy means making incision to remove the stone. So in cystolithotomy, surgeon opens the bladder through the incision and removes the stone. So here we have two codes. First code is 51050. And this code is used when surgeon opens the bladder and remove the stone that is actually located within the bladder. All right, so here the stone is in the bladder and incision is also made to the bladder. Next code we have 51065, and it is not used for a bladder stone. So you must carefully read the code language here. Here instead surgeon will open the bladder to reach the uretral opening and removes the fragments of the uretral stone through the bladder. So here the stone will be located in the uretral region. Okay, and that's when you use code 51065. So you can see the language bladder is surgically open to extract the fragment the uretral stone. Okay, all right, now we are going on to the last few slides. This is the last classification of approach. And this is a very unique category of urinary procedure or urinary stone removal procedure. Here, unlike the surgery we discussed so far, these procedures do not create surgical opening. Instead, surgeon performs endoscopy through already established artificial tract. So there is no new incision made. There will be an opening, and endoscope will be inserted through that opening, and surgeon will remove the stone. Okay, so the patient has already undergone a surgery and here he or she has an existing access track. Okay, so let's start with the codes. So renal endoscope, under renal endoscopy, here the surgeon will introduce the endoscope through existing nephrotomy or pilotomy track to access the kidney. Since this track already exists, no new incision is created, and CPT codes you will see here is 50570 and 50580. And next, let's move on to the lower urinary tract. So if the surgeon performs endoscopy through existing ureterostomy, you will report 50951 and 50961. And again, these procedures are use pre-existing ureterostomy or stoma rather than creating new incision. And finally, if the surgeon, instead of using existing ureterotomy track, the appropriate code family becomes 50970 or 50980. So you can see here established ureterotomy track is used. All right. So before we move on to the scenarios, let's all look at the topics which we have covered, or let's look at the main guidelines which we have covered. Okay, so Miss J usually say it as coding gem, so I've just renamed it here. It's coding pearls for urolithiasis. So 5 facts to remember before you code urolithiasis procedure. First one, the important one: identify the location or isolate the anatomy first. First question you should ask yourself is, where exactly is the stone? Is it in the kidney? Is it in the renal pelvis? Is it in the ureter, bladder, etc.? Now, never start looking the CPT code before you ask these questions. Start with the anatomy. All right. Second step, define the surgical approach or determine how the surgeon reached the stone. Was the procedure open, laparoscopic, percutaneous, endoscopic, or ESWL, which is extracorporeal shock wave lithotripsy? Okay. The third step, filter by PCNL complexity. So whenever you see PCNL or surgeries, don't immediately select the CPT code. Pause and ask, is the stone 2 centimeter or smaller or greater than 2 centimeter? Is it single non-branching stone or are multiple or branching stones present? Also, check whether the anatomy is straightforward or complex, because we have two codes for PCNL. One is simple and one is complex. Fourth one, read the parenthetical notes. So I would again stress on this one. This section has a lot of parenthetical guidelines associated with it, and that gives you an idea whether which services are bundled, which services are separately reported, or what modifiers you should use. So read parenthetical notes carefully. And finally, the fifth step, double check before you code. So before you move on to the next question, take 5 seconds to verify the things which we discussed. All right. So with that said, let's move on to the coding exercise. Okay, let's see what all we have learned so far by looking at these scenarios. I have few good scenarios for you all, and I would again request you all to actively participate in the chat. Place your answers. All right. So first question. Here we go. You have your CPT codes in this slide itself, so it might be much more easier for you to pick the correct answer. So which CPT code should be reported? Option A 51065, 51050, 50630, 52352. A 68-year-old male with a history of benign prostatic hyperplasia presents with severe dysuria and urinary retention. Imaging reveals massive 4.5 centimeter calculus located freely within the urinary bladder. Due to the size of the stone, the urologist elects to perform open surgical procedure. In the operating room, lower abdominal incision is made to access the pelvic cavity. The surgeon then makes a surgical incision directly into the bladder wall. Large bladder calculus is grasped and removed completely intact. The bladder is then carefully sutured, closed, followed by the closure of the abdominal incision. Which CPT code is reported for these services? All right, coders, you have time. All is already on. Timer is already on, and you can start placing the answers in the chat. All right. So I thought like I will give you a couple more seconds to place your answer. So great answers, great participation, coders. Excellent work. I really appreciate you all putting answers in the chat, irrespective of whether it's right or wrong. So let's go ahead and let's solve this one together. All right. So here we have a patient with 4.5 centimeter calculus that is located freely within the urinary bladder. So first question we have to ask is, where is the calculus actually located, right? So it is located in the urinary bladder. Second question was to identify the approach. What's the approach here? Open surgical removal was done. So it's an open approach which was performed, right? Okay. Now let's look at the options that we have. And you can see the surgical incision was made into the bladder wall. So doctor or the surgeon has made an incision into the bladder wall and located the urinary stone, bladder stone, and remove the stone. All right. So let's have a look at the CPT code options. We have 52352, which is coding for a cystourethropy. So did we have a cystourethropy? Was that the approach? Hmm. No, right? I don't think so. We had an open approach, not a cystourethropy approach. Cystourethropy is kind of endoscopic approach, right? So that's what we learned today. So option D has to go. It's incorrect. Next one. What's the next code? Okay. Next we have 50610, which is coding for a urethro 50610 50630. Okay, that is coding for a uretrolithotomy. Now this is an open procedure, but why is it incorrect? Can someone tell me in the chat? Why do you say 50630 is incorrect? Quickly, coders, let me know in the chat. I see majority of you have went with option B. So why is option C incorrect? It's also an open procedure, right? There you go. There you go. Excellent answers, Chari Sunny. Yes, you are correct. This is an open surgery which is performed on a ureter. You are absolutely right, Becky. So location, that's why I said location is important. Okay, Nazarene, great answer. So that makes option C incorrect. We're left with option A and B. Option A is coding for cystotomy with calculus, basket extraction, and or ultrasonic or electrohydraulic fragmentation of the ureteral calculus. So that is coding for a ureteral calculus, right? So you have to read that language clearly. So if you remember, I said for a bladder open surgery, there are two CPT codes. One is when the stone is located in the bladder and incision is made in the bladder and stone is removed. Second one, when the stone is located in the ureter but incision will be made through the bladder and stone will be extracted from the ureter or removed from the ureter. So we had stone location in the bladder. That's why option 51065 would be wrong. And the correct answer is going to be option B, 51050, as most of you have said. Excellent answer. I'm really impressed by the way you all solved this one. So great job, coders. Let's quickly move on to the next one. I have few questions for you all. So I want to make sure you cover most of them. So next one, I will start the timer. You can start answering the question. Option, which CPT codes should be reported? Option A, 52356. Option B, 52352. 52332. 51 modifier. Option C, 52320. 52332. 51 modifier. Option D, 52352. A 45-year-old female presents with 6 mm stone lodged in her right ureter. Surgeon performs a cystourethropy, advances ureteroscope into the right ureter, visualize the stone. Surgeon is able to capture the stone intact using stone basket, extract it completely without needing to use laser to fragment it. Following successful extraction, the surgeon places self-retaining indwelling double J stent to prevent post-operative swelling and ensure urine drainage. With CPT code should be reported. Okay, coders. So you remember those pearls, coding pearls, which I said. So apply it and you will arrive at the right answer. Okay, I can see a lot of options in the chat. This is a good scenario. This is a great scenario, and it might be a good teachable moment. So I will walk you through this one, Chorus. If you're still working on it, please go ahead and place your answers. Um, Great participation. Once again, I appreciate everyone placing the answers in the chat. Okay, so let's see the codes. Before that, what will happen here? The inventory. We have a patient with right ureter stone. So location of the stone is in the ureter. Procedure, we had a cystourethropy, we had a ureteroscopy, we had a self-retaining indwelling double J stent placement, right? These were the three procedures done. So approach is endoscopic approach. That is, everyone is agreeing to that. Okay, now let's look at the CPT code options 52356. So we had a lot of people going with option A, which is 52356. Let's read the code language for 52356. 52356 is for cystourethropy with ureteroscopy and or pyloscopy with lithotripsy, including insertion of indwelling ureteral stent. Okay, I think most of you went with that indwelling ureteral stent uh, language, right? Okay. Do anyone want to change it? If you read the question forensically, you might think, okay, let's change the answer some to other options. Do you want to change? All right. So, did we have a lithotripsy performed here or not? That was the question. Did we break down those stones using laser method or laser technique? So in lithotripsy, a laser technique will be used to break down large or big stones, urinary stones. Did we have a lithotripsy? In fact, It was clearly documented that surgeon able to capture the urinary stone or the stone intact using a stone basket and extract it completely without need to use a laser to fragment it. So there was no lithotripsy performed here. That's the reason why I would say 52356 is incorrect. Yes, Miss Mills. Aha moment. I hope that was an aha moment for you. Those who selected option A. Now moving on to the next one. So option A is incorrect. Let's remove option A. Okay. Now next one. 52355. No, option C. 52320. Again, I think let me look into the chat. Okay, no one selected option C. Okay, I thought most of you will go between option B and C. Okay, 52320 is coding for a cysto-urethroscopy with removal of the uretral calculus. Now, why is this incorrect? There is just small, a minute change or a minute element that is missing in this code from what procedure performed. So we had a cystourethropy, and if you carefully read, the scope was advanced, the ureteroscope was advanced into the right ureter to visualize the stone. So that is what we call as a ureteroscopy. So the ureter will be visualized, right? So we are not having a ureteroscopy in 52320, and I would say that a missing element is there, so 52320 is also incorrect. Between option B and option D, option B is coding for a cystourethropy with ureteroscopy and or pyloscopy with removal or manipulation of the calculus. Yes, we had a removal of the calculus done here. So 52352 fits in to all the procedures that was performed, and 52332 is in option B. 52332 is coding for cystourethropy with insertion of indwelling uretral stent. All right, so 52332 is not coding for a stent insertion, and that's why we would code 52332 along with it with the 51 modifier. And also you can see the guideline which states that report insertion of self-retaining indwelling stent performed during a diagnostic or a therapeutic cystourethropy with ureteroscopy and or pyloscopy. You would report 52332 in addition to the primary procedure. So the primary procedure was stone removal. Along with it, we have to report 52332 as well. Okay, so pay attention to those guidelines. How are you all doing, coders? All right, thank you for letting me know, Christy. How are you all doing? Wasn't that a great question? That was a good one, right? So that was a teachable one. Let me know in the chat. How are you all doing? Because I know I'm going at a little bit good pace. Uh, because I just want to you all to do maximum scenarios which I have with me today. Okay, so okay, we might go a bit past our usual time. I hope it's fine. Let me know, coders. How are you all doing? Good. Okay. Thank you for letting me know, Miss Linda. Let's move on to the next one. Exercise number 3. Based on the CPT guideline, how should the surgeon services be reported? Option A 50081 with a 50 modifier. Option B 50081. Option C 50081. 50080. Option D 50080 the 50 modifier. A 50-year-old patient presents to the operating room with bilateral kidney stones. Preoperative image reveals 3 centimeter branching calculus in the left kidney and 1.5 centimeter of non-branching stone in single location in the right kidney. The urologist performs PCNL or percutaneous nephrolithotomy on both kidneys. On the left, the surgeon creates a percutaneous tract, insert nephroscope, fragments the complex branching stone, extract the pieces and places nephrostomy tube. On the right, surgeon extract 1.5 centimeter stone through a percutaneous tract and places uretral stent. Based on the CPT guidelines, how should you how should the surgeon services be reported? All right, Kodas, your time begins now. Okay, apply the guidelines. That's your key for the scenario. Okay, okay, great answers. I think you had enough time to solve this one. So PCNL codes, as I said, are there are two PCNL codes. They are classified based on one, the size of the stone, whether and the what I can say morphology of the stone, as well as how number of stones located, and the anatomy of the procedure performed as well. Anatomy where the procedure performed as well, right? Okay, the first code is 50080, which is for PCNL simple. The next one is for complex. And in our scenario, patient had stone in both kidneys, in the left kidney as well as right kidney. And both are different types of stone, right? You can see one is branching, which is of 3 centimeter. The other one is non-branching, that is for 1.5 centimeter. And it was a PCNL which is performed on both the kidneys. Okay, so there you go. There is the guideline. The guideline states that when 50080 is performed on one side and 50081 is performed on the contralateral side, mod 550 is not applicable. And I think that's exactly what happened here. We have a left kidney with which is branching and 3 centimeter. So that qualifies for a complex PCNL procedure, right? And right kidney, you have a non-branching 1.5 centimeter stone, which qualifies for a simple PCNL procedure. Do you agree with me, Codus? Now, even though both are PCNL procedure, both are different type of PCNL performed in uh, both kidneys, right? So you cannot assign a 50 modifier here. You have to code them separately. And that's why I would say option A is wrong, option B is wrong, And the right answer is option C. I see that you all nailed this scenario, and I believe you all got the guidelines correct as well here. So, once again, excellent job. I think we can have one more scenario before we wind up. Here we go. I want you all to do this one as well. Okay, which CPT is the correct code? You can place your answers in the chat. Option A, 51050. 50630, 52352. Option D, 51065. A patient has stone lodged in their distal ureter. The surgeon decides to perform an open surgery, makes an incision directly into the bladder. There you go, there's a keyword. From inside the bladder, surgeon uses a basket to extract the calculus from the ureter. Which CPT code is the correct, or which best describe the procedure? Coders, your time begins now. I know you don't need 2.5 minutes, but since the last question, take your time. Place your answers in the chat. All right, that is time. And okay, I was just going through the chat. Right. Okay, Miss Mills, can you please guide Daisy Box Jewelry? Okay, or you can also reach out to us at contact at AMCI. Okay, I don't want to get it wrong. So can you please, someone from the team, can you guide or guide to the contact email address or just assist them? Okay, so let's solve this one, Codus. I think you all did a great job here. Okay, okay, thank you, Miss Mills. So let's solve this one uh, together. We have here an open surgery. That's the approach, open surgery. Where is the stone located? Bladder, right? No, not the bladder. The incision was made at the bladder, and the stone is located in the ureter, right? Yes, it is located in the ureter over here. So the CPT code 52352 is incorrect. That is coding for a cystourethropy, which is a endoscopic approach. No, that's wrong. Next one, 50610, not 610, 630, which is coding for a ureterolithotomy, which is an open procedure, but here incision is made into the ureter, not to the bladder. We had incision that was made at the bladder or into the bladder. So option B is also incorrect. Option A is coding for 51050, which is cystotomy with removal of the calculus without vesical neck resection. So here the calculus is located in the bladder, right? And we have 51065, which is coding for, okay, let me just look at, okay, cystotomy with calculus basket extraction and ultrasound and or ultrasonic or electrophilic electrohydraulic fragmentation of the ureter status calculus. So you can see the location of the stone here. It's ureteral calculus. And where did the incision happen? Cystotomy, right? So that happened in the bladder. And that makes option T the correct answer. How are you all doing, coders? I actually had three more scenarios ready for you all today, but we almost reached our time, and that's why I would have to conclude. So let me know, coders, how did you do today? Did the session help you to feel or help you to feel more confident with the urolithiasis coding? let let me know in the chat. Did you learn how to do the do you understood how to code those urolithiasis procedure, the pearls which I gave? Approach is important, the anatomy is important, parenthetical guidelines are important. Okay, that's fine. Okay, all right. So if you think you need a little bit more practice, the playback is always available, so don't forget to go and see the playback. Because I always say mastery doesn't happen in one session. It happens with consistent learning, repetition, and right support, which we are here to provide. All right. So I am placing the survey links and coders. Before that, you can find all these playbacks and all our mastery session videos, CPT guideline mastery session. So we go very strong on those CPT guidelines. You can find these videos in our playlist. Go to the playlist and you will find CPT guideline mastery. That's the name of the playlist, and you will find a lot of, I think, valuable lecture videos over there. We cover several topics on a weekly basis, so you will find a lot of guideline mastery sessions. Please feel free to go there, and also let us know if you like the lecture. You can comment with a comment in those videos, like them. Also fill out the survey form over here. That's one way to let us know that these sessions are really helping you. Okay, I would really request you all to take a moment to fill out that survey form. I can see we had more than 25 students here, so I expect everyone, please, to fill out that survey form. That's how you will let us know that these sessions are helping you, and that will also help us to bring more and more such sessions to you. Please do take a moment, just take 1 minute and let us know your thoughts. That's all we ask. Also, if you like the session, if you enjoyed it, and if you find it valuable, please don't forget to smash that like button, subscribe to our AMCI channel, and share it with someone who really need to see it. Okay, so coders, next week we will be, it's week 5 here at AMCI, and I think we will be covering which topics, maybe Python lab. So please make sure, coders, let us know which all topic do you want us to cover in the next class. As I said, I took this topic from one of your suggestion, one suggestion from among you. So let us know what other topics are you looking forward to, and that will, I would really consider to take a session on them. Okay. So it's really helping me also to select the topics. So go ahead, coders, you can let us know with the help of the survey links. It's in the chat, and we'll all see you next Friday. Till then, keep coding. Thank you, Miss Mills. Thank you, Miss Catherine. Thank you, team. Thank you, everyone. Thank you, coders, for attending this session. And I wish you all a great rest of the day and a great weekend ahead. See you all next weekend. Till then, keep coding, stay safe, and have a great rest of the day. Bye.
4,000 exam passers and free classes time to go straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI, AMCI.